Okay. Do you have any problem if we record the session, the meeting? No.
Of course not.
Thank you very much. Is Prono yet in the market currently? Yes.
Yes, we are in the market.
So you will explain us everything, and we'll make the questions and answer after your presentation. I am not, because I really want to know a lot of things, but I can wait.
We want to know also from your side.
Okay, we are not going to participate as speaker, but we are an association of Parkinson here in Spain.
Yes, but we can keep in contact and
of course. Of course, you are also involved in European projects.
What do you mean?
Have you got experience with projects, European projects in Horizon 2020?
Not yet. Individually, yes, but not as this company now that we have formed.
So the way that you generate the investors of the Prono are the government or individual or companies?
From companies, from employers, from sponsorships, yes.
Okay.
From private funding.
Private funding is
so far.
Because it's very difficult to get into the market with any technological whatever. So, and what about virtual reality, Aklina? Is in the market? Is currently no yet.
It is not in the market yet. We are still doing clinical trials and with different group of patients in different rehabilitation centers. So right now, yes, it is. We have finished the design, we have finished the trials, and maybe the next month we will try to put it on market, but till now it's more in research use.
The experience of getting to the market is very complicated for rehabilitation, because if they think that these are medical devices, they treat them as a medicine. So you have to pass through all the paths, all the steps in order to get the license to be used.
And actually our team is more like clinicians, so we have no experience with putting a product in market. So we had to hire like another company to do all of the things. But yes, for us, it's like something totally new.
And very, very complicated and very expensive also. To have the CE marked, you know, for use in Europe is very, very complicated also.
Yes.
So
can I ask, would you be interested that we broadcast on YouTube, so afterward we can have it there? Or you prefer not?
No, that shouldn't be a problem, of course.
It's okay for you. Perfect.
Absolutely.
We will ask to Antonis about PD monitor if he has problem, because he's not here.
Yes, of course.
Okay. Sasa is here from Serbian Braille Council, and do you know if someone from Belgian Brain Council is going to?
I know that Roland from Belgian Brain Council is traveling today by train in France, so he won't be able to join. And he asked from somebody else, but I guess if they're not here yet, we can start.
Okay. So we are going to start then, and it is very important for being recording this, because we are going to share with the partnership. So is perfect. So go ahead and we will welcome to Anthony's from PD Monitor when he starts the connection. Okay, I'm Laura Carrasco from Parkinson Matrix Association. My role here is because we are the coordinator of this project, European project that belongs to the Erasmus Plus program. The name is E-Care4PD. And the main objective of this project is just to exchange good practice in e-health care for adults with Parkinson's and their family caregivers in Europe. This project is born to provide solution and bet on technology, digital connect, and good practice as facilitating tools to contribute to the well-being and improvement of quality of life of those who are affected by Parkinson. So the final product of this project will be a good practice guide. We are compiling a lot of good practice that are currently in the market or in the research. All the things, all the projects that are now running, and we are trying to compile this, to generate this good practice and to share with those stakeholders that are interested on it. Okay, Aquilina, we lost Aquilina, but she's here again. Okay, the consortium, we belong to several organizations. Belgian Brain Council, Grid Care Network, Epioni, this is Spiros, that I want to thank Spiros because his organization, Epioni, is the one who has organized this meeting. So thank you very much, Spiros, for organizing this meeting. And of course, the Serbian Brain Council, that is Sasa somewhere here. He's a neurologist. And okay, Sasa, good morning. And I want to thank you especially for all of the speakers for your generosity in order to disseminate your knowledge and exchange and give your experience with us. Okay, so we firstly will have Aquilina Despoti. She's a clinical neuropsychologist, researcher in clinical ergospirometry and exercise and rehabilitation lab. She belongs to a School of Medicine, National Podistria University of Athens, and she will talk about virtual reality application in Parkinson patients. Aquilina, we are the only two girls in the in the group, so you can easily recognize her. And after that, we will talk. We will listen to Antonis Papadimitriou. PD. He's going to talk about PD Monitor. He's the senior sales and marketing executive of PD Neurotechnology Medical Solution and Enterprise. So thank you very much, Antonis Papadimitriou, for contacting. You are still here? Yeah, he is. Hello, Antonis. And finally, we listen about Pronu, that is a platform for caregivers. And with George Tinolassos, and also Yanis Basilakos, that both are co-founders of Prono Software Development, are going to explain us. So thank you very much, all of you and Spiro, and we can start. All the floor is yours, Aquilina. Thank you very much.
Thank you so much, Laura. And
excuse me, wait a minute, Anthony. Do you mind if we are recording the session meeting, and also it's in streaming now in YouTube? Have you got any problem with this?
No problems at all.
Oh, thank you very much. So go ahead. Sorry, Aquilina.
Okay, thank you so much. It's so nice meeting you all, and I'm very happy to participate in this meeting of E-Care4PD. So I'm going to present you some virtual reality application that we have created for different patients with neurological diseases, which also includes patients with Parkinson's disease. So we are actually starting more and more to be part of clinical trials as a method of rehabilitation. And this is because it gives a very great flexibility to the therapists. Also, the tests and the programs can very easily be adapted, and the therapist has a very great control over the therapy. Also, it's a great tool for personalization, so the exercise and the training can be very much personalized in the needs of every patient. It's a very realistic environment. It has a very great safety, and the most great thing is that all the responses of the patients can be recorded in a very great accuracy that is not possible with a human observation. But however, so there are many VR tools right now in the market, but in the research we have mostly non or semi-immersive virtual reality applications and not fully immersive VR. And the higher the immersive is, the higher the presence in the space.
Jacqueline, sorry, are you changing the
Yes.
because we can see the changes. Maybe if you we are
Oh.
in the first one, in the very first one.
Okay.
Okay, perfect.
Let
Thank
me
you.
try again to share screen. Okay. Now, can you see the change? Can you see the
Yes,
screen?
we are seeing the fifth one. It's a different photographs, non-immersive, semi-immersive, and fully immersive.
Okay.
Is what we see now.
Okay, I see that it is not easy to move when I put it full screen, so I will continue with yes.
Not full screen. Okay,
Yes,
thank you.
exactly. So we have different technologies in VR applications. We have non-immersive VR, which is mostly screen and some interactions. We have semi-immersive, which is 3D or very big screens that the participant can participate and do some exercises. And then we have the full immersive, which is with the glasses and the controllers or non-controllers. So when it comes to Parkinson, we have already many applications in VR that mostly train the physical symptoms of Parkinson's. And mainly we have VR for training the balance and the gait, and also the upper limb movement. But also we have many VR training the cognitive functions of Parkinson patients. And all of these studies, they seem very promising for the VR. So when we compare virtual reality with physical therapy, we see that VR has good improvements in the balance, in the motor skills, in gait, and also in the upper limb control, which is the tremor, the strength, the speed, the accuracy of the movement. And of course, also in cognitive functions, and we have very good results in the overall cognitive function, but also in the executive. And also we have some VR applications that seem to improve a lot the mood, and more specifically the depression. So overall, it seems that VR, it's a good and a supportive method for the physical and the cognitive rehabilitation. But one of the limitations is that all of these studies, they have good quality, but we have a higher demand for high quality research in this area. So these interventions, they mostly they last around 30 minutes, and it can start from 1 session to 60 sessions. And some VR environments include navigation into the space with some exercises of the everyday life, as walking or doing cycling or doing exercises in the kitchen or in the house. One of the negative things of VR is the simulation sickness that can be created in the virtual reality environment, or otherwise we can call it motion sickness. And this is a feeling of dizziness and disorientation into the virtual reality, and can be created especially when you have a lot of movement into the VR and a lot of image changes. And of course, patients that have epilepsy, they cannot participate into these exercises. So coming to our project, REACT project, it is a multidisciplinary team that also physiotherapists, occupational therapists, neuropsychologists have been participated to create a fully immersive VR program that combines cognitive and physical rehabilitation at the same time. And it has been created to treat patients with various neurological diseases, as stroke, as TBI, but also with patients with Parkinson disease. So till now we have 2 games. The first game is occupational therapy kind of scenario, where participants have to cut some balls into a table, where in the first game they have to exercise the naming. So they have to fill the same ball with the same color in the to match them. In the second one, they have a very big box where they had to put inside objects with the same color. And then in the second scenario, we have the participants are in a field where they have goats and coming in front of them, and they have to distinguish white goats in the right side or black sheep in the left side. Also, I have to mention that this program has been created for the early stages of rehabilitation. So it is for patients that are starting right now, and their cognitive functions are in a very early stages, as well as their physical rehabilitation. And we created the first pilot study to test the safety and the feasibility of this fully immersive VR. And we included patients actually starting with stroke because this was more easy in the rehabilitation center. We had more patients with stroke, so we started examining the VR to them. And we tested the safety and the feasibility with the SEC questionnaire, Sustainability Evaluation Questionnaire for Virtual Reality Systems. And we translated it in the Greek language, and also we included some more extra questions about the therapists, where also therapists can give feedback whether the program was easy for the patients, if it was easy to use for them, and if they have to recommend any changes. We gave the SEC questionnaire in the first and the last session. So the results are quite good. So we conducted 27 sessions in this first pilot study. Every session lasted from 8 to 12 minutes. And the feedback that we got is that very good. It was 61. The top score that someone can get is 63. So the participants really liked the VR, also they think it is safe. We have no negative symptoms. Only one participant stated that they had a bit of dizziness in the beginning, but this was very, very mild, and it did not interrupt the session. Also, the therapists gave a good feedback. They think that the VR is very easy to use, and it is also easy to use for them, but also easy for the patients. So, going to the conclusions, it seems that a VR can be safe and easy to use, and they can have a very good impact in cognitive and physical rehabilitation. Some challenges that we have is that till now all the research includes small sample in the patients. We have a lack of follow-up in many studies, which creates a question about the ecological validity of the virtual reality programs. We don't have a lot of data about the early stages of rehabilitations. And many studies, they don't really report many details about the intervention, about the evaluation that they did before or they did after. So some ideas for future studies. I think we really need bigger, large-scale, longitudinal clinical studies. And also, more specifically, we need more RCTs, more randomized controlled trials to test in various groups of patients. And also, it would be very nice to combine and test the difference between immersion and non-immersive VR environments. And also to combine VR with other technological tools as EEG, or fMRI. This is our team. It's a very big team with many different therapies. We have physical therapists, occupational therapists, our professor, which is a professor in ICU clinic. And of course, here we have the team which creates all of the VR. They are designers and developers. And thank you for your attention.
Thank you very much, Aklina. Thank you. If you have time, we can wait until the end for questions. Okay, if you don't mind. Okay, thank you very much then. So let's go for the next one. Would be Antonis Papadimetrius with PD Monitor.
Thank you.
Thank you, Anthony.
Thank you for inviting me here to speak about PD Monitor. Let me share my screen. I have prepared a small presentation. Just give me a second to find the PowerPoints. I haven't used a Zoom for a while, so okay. So I hope you can see my screen.
Yes, Anthony.
Excellent. So I'm Antonis Papadimetriou. I'm a senior sales marketing executive in PD Neurotechnology. PD Neurotechnology is a company. It's a UK company. Started in 2015, a commercialized product that has started back in 2006 as an idea, as a concept. And the concept was to have an objective.
Anthony, sorry, we have some problems to hear you. Maybe if you, when you're talking, you are just putting your hands before you, the sounds, they disappears.
Okay.
Thank you.
Is it better now?
Yeah, I think. It's not very good, the sound anyway, but we can hear you.
Okay, this project started back in the University of Ioannina in 2006 as a research project. And the aim was to have an objective monitoring of motor symptoms in Parkinson disease patients. which was quite difficult. Parkinson's is a quite complex disease. The symptoms are quite, they look like each other, and it was very easy for the patient to confuse them. So after many years of research, PD monitor.
Sorry again, Anthony. Sorry. I think that maybe you are changing the different pages, but we can see them. So if you get out from the full screen presentation, it's easier, because I don't know what happened with Zoom and PowerPoint when you're presenting, when we are presenting in full screen, that we can see the change. Let's see.
It's better now.
No, I think that you are not changing the different pages. Have you changed before the pages, or are you still in the first one?
Okay. Now?
Okay, perfect.
Okay.
Perfect.
So I wasn't really good changing pages. I just wanted to give you an introduction on the device before actually showing the pictures. So what was created was a device with 5 sensors, wearable sensors that you can see here on the page. We have 2 sensors being worn by the patient on the arms, exactly like wear a wrist. 2 sensors being worn on the legs, on the shank level, and 1 on the waist. So by wearing these sensors from the morning till before the patient goes to sleep in the evening, we monitor all the movement of the patient during the day. Inside these sensors are various movement sensors, a gyroscope, an accelerometer, a magnetometer. Also, there is a memory card and a battery to keep all the system live. So we monitor everything. All these sensors are.
I beg your pardon, Anthony, again. We have some problems with your communication. Do you have headphones or something like a microphone?
Let me just try to.
It is because the sound, we hear you very, very, very down. Let's see. You have microphone with the headphones, maybe?
I've used.
Wow, much better. Thank you very much. Much better. They are quite different. Thank you.
So at the end of the day, when the patient finishes the monitoring session, they put these devices on this base here, which is called SmartBox, and the processing starts. So let's see what happens. So this green box is the monitoring device that the patient actually wear on the body. It contains various sensors inside. At the end of the day, the patient puts the sensor on the SmartBox, where all this raw data is being processed, and with special machine learning algorithms, we extract the symptoms of Parkinson's disease patients that we are mainly interested in, and we actually upload this in a cloud, in the PD monitoring cloud. This is a safe cloud. This is Microsoft Azure cloud because it contains sensitive information, and all the information is being kept there. As well, apart from the sensors, either the patient or the caregiver have a mobile app. What we ask them to fill in the mobile app is information about their medication, to count their adherence to the medication. So we actually register all the medication times, and we ask them to confirm every time they got a pill, and also tell us the real time they got the pill in case they forgot. Also, they give us information about their nutrition, what they had for dinner or for lunch, especially if there was a food involving protein. And also they can send an open message to their physician for anything that they think is important for the physician to know. So all this information, both from the sensor and from the mobile app, either from the caregiver or the patient, is being collected to the PD monitor cloud, and then it is sent in the form of a very detailed report to the physician. This is the mobile app I explained before. I mean, you can see here the atypical medication list. Also, some icons that we ask them to fill regarding food, if they had fish, meat, dairy products, or eggs, or anything else. Also, we provide them some at the end of the monitoring session, which is a typical monitoring session will be from 2 to 5 consecutive days. We provide them with some statistics about their activity, how active they were, the percentage of time they were walking, they were sleeping, or they were sitting. So the patient can actually realize a lot of details about their routine that before maybe they didn't. And all this information is being collected and presented to the doctor in a very, very nice way, in a form of a diagram and also in a form of a card. So the physician can, the neurologist or the physician can actually see all the symptoms in a very nice diagrammatic way for all these days, and they see how the patient actually reacts to medication. These lines here are the times of medication, and the bars represent for this diagram the off sessions. So the higher the bar, the more off is the patient. The probability of the patient being off is higher, and clearly the patient can have a lot of information about how the patient reacts to medication, how the patient takes the medication, if they are accurate or not, and we provide a lot of information so the doctor can make decisions to fine-tune the medication of the patient, either add, change, reduce, depending on the symptoms. This actually is leading us, this device can help us to go to a different paradigm. This is a very important slide, because here we can see in the first part what can happen without PD monitor in the course of few months. A typical visit to neurologist of a Parkinson's disease patient would be about 4 to 6 months. So in these 4 to 6 months, without PD monitor, the doctor receives some random phone calls where the objectivity of the data is not really high, either from the patient themselves or from caregivers. The doctor doesn't have a very clear understanding of what is going on till the next visit. With the PD monitor, all this changes. The doctor can actually request the patient to wear PD monitor to get an idea, to get an understanding of the symptoms. And also, very importantly, the doctor can be proactive. They can call the patient, and then they can ask them to change something, medication, nutrition, or habit, with the result to have much better control symptoms, the patient to be more self-managed because they feel that the doctor knows what is going on. Also, the usage of the app helps us a lot for the patient to understand the daily routine. And everybody is fully empowered and participatory and participant in the disease management. These are the basic symptoms we track, we depict from PD monitor. Well, gait, this is very, very basic for the patients, because it affects the quality of gait, affects the quality of life in general. Of course, we track tremor, bradykinesia, which is very basic symptom of Parkinson's, dyskinesia, which is a side effect of medication, freeze of gait, which is another effect of gait, and also postural instability, which gives the neurologist the idea of progression of the disease. All patients, all these symptoms are being monitored and being produced in the report, and help the neurologist to understand. They can see every single symptom in every single extremity, and so they know the disease progression, and they can make decisions regarding the patient, either for medication change or maybe decide if a patient is eligible for advanced therapy like deep brain simulation or apomorphine pump or anything else. Overall, of course, there is an objective evaluation that PD Monitor offers, and we can see all motor fluctuation and complications, and also what I said earlier, that all this can lead us to therapy modification, but based on accurate data. We can monitor the course of Parkinson's disease over time. We can monitor when the disease is actually progressing from one body site to another, and decide for any other interventions. We can have a very good idea of what is the patient doing in the everyday life, in their home, in their natural environment, and not in the hospital. This is more realistic. Of course, we can understand the patient complaints and actually rate them if they are pragmatic or not. And the neurologist can understand much better what is going on. We have all 5 sensors, and also we get, as I said before, a full icon of all body parts and of all symptoms, including the gait. Gait is very important for the quality of life of the patient. We offer active participation of the patient and his or her caregiver. And all this can save a lot of time during the next visit to the physician, because the physician will actually have a lot of data to discuss and will not waste any time in trying to understand what happened in the last 5-6 months that they haven't seen the patient. And this could help the physician actually getting a more accurate therapy for the patient, help them more, and make them well, this is too much to say. At the end of the day, we need to improve the quality of life of the patient. And when we have a well-controlled patient, if their symptoms are well controlled as much as possible, of course, Parkinson's disease is a degenerative disease. I mean, it will go worse over time. But our aim here is to keep the patient at a good level for as much as possible by very well controlling their therapy. Of course, this information can be shared with other healthcare professionals, except the physician, like a PD nurse. In some countries, PD nurse has a very active role in the management of the patients. Of course, physiotherapist, occupational speech therapist, if it exists in the healthcare system. Of course, the caregiver, which plays a very important role in the patient's advancement and care, and any other healthcare professional that is involved in the patient's journey in Parkinson's. Also, we have, of course, as I said before, we can be proactive using this kind of tool. We can be preventive by seeing symptoms and try to act upon. This is all personalized because Parkinson's disease is very different in each patient and has different symptoms. And of course, participatory, as the patient actually participates in their therapy, make them and understands better their disease during using all these monitoring tools. And that was very briefly PD Monitor. I mean, we could say a lot more. There are a lot of publications, there are a lot of studies, there are a lot of people that have been used in PD Monitor in many countries. But in the interest of time, that was a very brief presentation. Please ask any questions at the end. I will be more than happy to answer.
Thank you very much, Anthony. It's very clear. We have I have a lot of questions for the more.
Very well.
Thank you. Thank you very much. Let's go through George, maybe, with Prono.
Yes, thank you very much. Thank you very much for the invitation and the opportunity to be here with you today. Hopefully you can see my screen. So I'm George Dinolazos. I'm one of the co-founders, and I'm based in London. My background is in digital transformations, and I've worked with over the last 20, 30 years with startups and in different sectors. In the space of healthcare, I've worked with lots of startups and big companies like GlaxoSmithKline, and I have been for 3 years the interim head of data for the European Medicines Agency. With me on the call is also Yannis Vasilakos. He's my fellow co-founder of Prono, and he's a seasoned business development manager in healthcare IT in Greece and across Europe. So Prono is a social tech startup, and our mission is to empower and support informal carers and the people they care for. And what we're gonna show you is our flagship product, our platform called Prono Care. Before we go there, it's taking a moment to see what life-changing moments we all live. My father passed away almost 7 years ago, and he lived with the disease for 8 years. His life-changing moment was when he was diagnosed with Parkinson's disease. And these life-changing moments happen around us all the time. When Maria is being diagnosed with Alzheimer's, when Mike is being told that the shadow in his X-ray is actually cancer, when John had this car accident 5 months ago and the pain is still there, when Nick had a stroke, when the grandma stopped recognizing her family, where Helen been told that the therapy didn't work, when the dad receives the last visit from his son, from his daughter and granddaughter. So these are life-changing moments, and they change not just these people's lives, they change the lives of the families. And the families suddenly become carers. And as a carer, they are there to hear what these people hear, there to see what they see, there to feel what they feel. These are the carers. And when you're a carer, it's almost like you're taking a responsibility you know nothing about. Life is almost like that white space we see on the screen right now. You're feeling not lost. You know nothing about the disease. You know nothing about your responsibilities. Nobody told you anything about how to do proper caregiving. But nevertheless, you have to go and assist with activities of daily living, food, personal care, medications, mental, emotional well-being, doing errands, housework, mobility, and worrying about financial and legal matters. And you also have to coordinate care with family and friends. You have to navigate a labyrinth of services, both primary care services or secondary care services. In the approach to find hope, you might be looking at even clinical trials, developments in health and healthcare, and you need to coordinate care with all of these professionals. And in order to coordinate, you need to know about symptoms, medication, you need to learn about the disease, record things, organize things, communicate all of this health information. And always be aware that you need to do short-term and long-term planning. In my mind, when we talk about care, caregiving, carer, they all sound like soft, compassionate, human things, but the reality is brutal, it's cruel, it's exhausting both physically and mentally. But if your loved ones need care, then they need care. So Prono is there. We've created Prono for these informal carers to lift some of their burdens, to give them back some of the time, to be the compass on that journey of caring for the loved ones. and to extend the care circle so they never feel alone. So what does Prono do? The journey starts with downloading the app, creating your account. You could apply a sponsorship, whether this comes from a not-for-profit organization, your employer. And if you're a caregiver, you can create an account for the care recipient. And the idea here is this diary, this Prono app can be used both for you as a carer and the person who receives care. So what can you do with the app? One of the things we have is to be able to record all the health and lifestyle data. So you're recording things like diet, sleep, activities, water intake, habits you might have either as a caregiver or a patient. You're recording all the vitals, blood pressure, heart rate, blood glucose, body temperature, body oxygen levels. And you can keep track of your existing conditions, medication alerts, lab results, vaccinations, and allergies. And what the app does, it can give you an overview of the health over time. Here you can see your blood pressure over time, your heart rate, or even your medication adherence, whether the patient has taken the medication on time or missed some of the dosages. So this is all about recording information. But then you need to connect and coordinate help. So we have this concept of creating a circle of care where you can invite and connect on these shared, if you like, calendars and records, your family and friends. You can search and connect professional services, nurses, doctors, dietitians, everyone who might be offering help at home. And then this personal circle of care, they all have access to every information you're sharing with them. So you're creating an extended care circle to support you through these different stages of caregiving and the different stages of the caregiving continuum. And then you need to have plans. You recorded your medical information, your health information, and what we do is you have a plan of the tasks for that specific day. And you can have log entries, things that you do in that specific day. You can do things like activities of daily living, instrumental activities of daily living, or even specialized activities where they need specialized skills from either doctors, nurses, physiotherapists, and other activities. Part of the logbook here, especially for people who have Parkinson's, what we've seen is they use it to record the symptoms and the change of symptoms, their emotions, and also the diets, but also all of these other activities, which are activities of every day, so you can plan and ask for help. One of the biggest things with carers is that they might be supporting the extended network of family and friends, but it's not very easy for someone to go constantly on a daily basis asking for help. By connecting these people on the platform, you can see the to-dos, the things that need to be done on that day, and then people can offer and volunteer help with no need to actually ask for it. In terms of last part we have in the presentation today is all around learning. As we said, when you start this role as of a caregiver, one of the big gaps you have in terms of resources for events that you can attend and learn new things, useful links to not-for-profit organizations, and you might be getting information about medicine recalls across the spectrum of the medication you're taking. All of these types of information can be managed by the sponsor, as we said, of the application. So it could be personalized based on what disease and location the patient and or caregiver live in. So the information will be slightly different in terms of what they see. A recent addition, which we are very proud of, is the idea of having a chatbot. And the idea is that the caregiver and or patient can ask questions and get responses back in terms of these questions for the disease or the care plan or any other question that they have. Our chatbot is based on ChatGPT and is the latest version, number 4, but it's trained. We have different chatbot instances, but the one we have for Parkinson's is trained on publicly available resources. So these could be documents from research, from not-for-profit organizations, and it's one of the things we will want to do is to feed these types of, for example, the good practice for caring for someone with Parkinson's or living with Parkinson's. These documents can be fed into the chatbot, and then they become the knowledge base for having conversations with the caregivers and or patients. And the chatbot is available in our application, but it's also available as a separate instance for websites as well. So one of the key things here is it's not a generic chatbot, it's a chatbot that is specifically trained on documents that have been validated either through NGOs, research, and peer-to-peer publications. So as we've seen, technology, we don't think can replace the human touch for providing care, but it could help with recording, planning, connecting, and learning across the caregiving continuum. We offer the e-health and the lifestyle profile management, a shared care plan schedule where both caregivers, patients, and everyone else in the network, professionals or not, can see and add information. A dietitian can add all of the diet plan. A doctor can add the medication. The nurse can add specific things in terms of exercises and so on and so on. And they're all shared with everyone in the platform. And the circle of care, as we said, you have an extended network of support and new information and educational resources altogether. You can download the app on our website and see it for yourself. But the more important thing for us is that we think we believe in collaboration, and together we can do more. So we work with not-for-profit organizations to offer free access to our platform, but also we want to have partnerships in order to serve this content, the best practices, information for all of these patients and caregivers, for people who have Parkinson's, but also any other people who need care. And that's.
Thank you very much, George. It's very clear also. Okay. I have several questions because we start with this part of the we are on time very good. And so we are on time, very good. So if you have some question, because I am the moderator, so I keep to the end, but please go ahead and participate also between you, the speakers, if you have some questions to others. So Sasa.
Actually, I don't have a question. I mean, I just have to apologize because something was wrong with my presentation and appearance. I'm here and you can hear me. I hope I can see by your face that you can hear me, but you cannot see me. I tried everything possible except to restart Windows, which I didn't want to do that. So sorry about it.
Okay. We can hear you, Sasa. You have some questions?
Yes. No, I said that I don't have particular question. I mean, I was just listening to your presentation, so I just wanted to use this opportunity to apologize. So
Okay.
Sorry. Thank you for all the speakers. It was really nice and fruitful, and something which will help us, because we will be the next presenter for this good practice exchange. I mean, our society. So.
Thank you very much, Asa. Okay, so do you have some question? Any question from your side, speakers or Spiros? No? So I go.
No, I don't
Spiros.
have any questions. Thank you to all the for all the presentations. It's nice to meet virtually, and I think we will meet in Madrid at some point at the end of the project.
Perfect. Thank you very much, Spiros. Okay, so I go in order. So the first question goes to Aglina. What are the strengths? What do you think are the strengths of your virtual reality application if you compare with others that are in the market currently? What's the difference you think they are, or the strengths of your reality? Because this is like it's like a run. Everybody go very fast, and it's difficult because the market is still, you know, it is a new market, but no, there are not so many applications, but are some that they did very good with the marketing, and so on, with a lot of effort, of course. And what's your think is your strengths, or what do you take new from the things that there are?
I think it's one of the very few programs that combine cognitive and physical rehabilitation at the same time in the exercises. Also, it is a tool that is designed for patients in the very early stages of rehabilitation. And also it is specifically designed for patients, because many of the scenarios and the games that are in the market, they mainly designed for, I think, healthy participants, because we were trying to play and to interact with them, and they were very difficult, they were very demanding. A patient with cognitive impairment, it's not possible to participate. Also, the graphics inside are very complicated. They are very fast. They have a lot of stimulation, and it is more easy to create simulation sickness. So yes.
Do you have any experience, Aglina? Because when we try here in our rehabilitation center with Parkinson disease, the full immersive or reality, virtual reality, we found that some of them they have some problems with the proprioception. They lose the balance and really don't know where they are. Maybe it's not safety. What's your experience with that? We are very afraid about it.
Yes. So we have tested till now the VR with patients seated. They are not standing, which makes a big difference because it is more safe for them, especially in the beginning when they don't really know what exactly they have to do. It is more good for them to be seated. So they are seated, and also the VR that we have created is very simple inside. It has not many information, not a very complicated background. So it is more easy for them to focus. Till now, we had not cases of feeling that they will fall or something like that. Also because maybe in the VR, they also see themselves seated and they don't see themselves standing, which also makes a difference. And also because they are stable in the game. They don't see themselves moving or walking or something like that. So yes, that's why we need more programs that are designed for patients. They're not designed for a healthy participant or like a gamer, because it is a very big difference.
In fact, I have a question regarding if you are trying to rehabilitate at the same time cognitive and physical, that you combine both. If they are sitting, how do you do with the inferior, members with legs and things like that, or balance or gait? That is a very typical Parkinson disease rehabilitation. How can you manage?
So right now we train the upper limb motion till now and the cognitive functions. Now we are going to start training also the standing and the balance. But still now we were training the upper limb motion and the cognitive function, so we didn't have standing.
Okay, taking into account, I don't know the article, but there are some articles that said that in Parkinson's disease it's very difficult for them to do two different things at the same time. So they have to focus on one, otherwise they can't, they have some problems. So maybe it is very important to take into account this kind of cognitive characteristic in Parkinson's disease. So I don't know if other centers can use or have some experience with it. You are sharing, or there are some passport that you can share with others, or is just focus on in a clinical trial?
Yes, till now, but I can definitely keep your emails and send you maybe some videos, or the moment it is ready in the market, I can definitely let you know and you can try it.
Okay, thank you very much. So let's go to PD monitor. We have some experience, Antonis, with maybe your the Parkinson staton in Spain. Maybe it's your competitor.
Yes, this is a competitor. Yes,
the competitor. We have some experience because in Spain they are Spanish, so they are working very hard with it. I saw you in movement disorders in Madrid in last September.
I was there.
I've been in your stand.
Yeah. Okay. Great. I think I remember you. I remember you.
Maybe. Okay. So the difficulties that we find here in Spain in the practice in currently in the daily life practice is the indication. Who can indicate the PD monitor? I mean, can the patients ask or order it directly to a website, or they have to wait that someone indicates?
This is actually a neurologist's decision. I mean, the neurologist decides which patient is eligible for PD monitor, and from the neurologist, all this process is initiated because every patient is different. I mean, every patient has different needs. So the patient decides, the neurologist decides for which patient PD monitor could be more beneficial, depending on their situation, on their current status, on their medication, and everything.
Okay, and how do you find the acceptance of the neurologists? Because in Spain, at least my experience is very hard. They are not. I mean, the technology is everywhere, but in order to use it,
my experience in Spain is very limited, to be honest with you. But in other countries, like in Greece, the acceptance is fine. I mean, of course, you have like all technologies, you have to explain very well how the technology works. You have to train them. You have to be there to support in every need they have regarding how to read the report. Also, you have to train the patient on the other side how to use the wearables correctly. It's a process. I mean, like everything new, it's a process. It's a learning process. It's not always easy, but it's interesting.
And the other two issues that I can imagine that could happen is the second one is who pays for that? Is the patient? Is the hospitals? Who pays for that?
That depends on the country, actually. Usually, hospitals pay for that. Usually.
So I can imagine that the Department of Neurologists have several PD monitor, and they
yes. I mean, again, it depends on the country and the model. But if this is one scenario. I mean, one scenario is for the hospital to have several PD monitor and give them to the patients for monitoring. Another scenario is for the patient to take the device home and keep it for some time, for a few months or a year. That depends on the situation. These are the two basic scenarios. Yes.
Okay. If it is useful for you, we are extending one practice here in Madrid that we want to spread in all around Spain. Is that the association of patients are promoting that the people use this kind of technology in order to prepare the consult, neurology consult, because I don't know how it goes in other countries, but in Spain we have only 10 minutes or maybe 15 minutes, sometimes every 6 months or even more, even worse.
And it is similar to other countries. I mean, unfortunately, a typical consultation time will be about 20 minutes, 15 to 20 minutes. A follow-up, maybe the first consultation will be a bit longer, but a follow-up will be about 15 minutes. In these 15 minutes, you have to present a lot of information.
That's it.
Which is like, if you haven't seen your neurologist for like 4 or 5 months, there is a lot accumulated, and PD monitor helps you exactly in this. I mean, the neurologist has already some information, and it's very targeted, very specialized in the questions they make.
So the logistic is easy. I mean, because the patients in hospital goes for example, every 5 months, for example, and if they take the PD monitor at home, they have to return it in several days, I suppose, or for how long time?
They can keep it for, that depends on the case, really. They can keep it either for one session or for a couple of months or 3 months, and then we arrange for the PD monitor to be collected. This is not a problem. Of course, either the hospital or either ourselves or our distributor in the country provide some training to the patient at their home. That again depends on the country. The exact details depends on the country of operation. But logistic is being taken care of. This is not a problem.
Okay, I see if I have another one. Okay, thank you very much, Anthony.
Thank you. Thank you.
And let's go to Prono. Again, what is your business model? I mean, it is perfect, it's useful, but who pay for it? How do you go to people? How you can get into the market? How the people can use it?
The business model we have is mainly business to business. As we know, from Eurocarer stats, there are approximately 76 million carers, informal carers in Europe alone. And 50% of them are actually combined caregiving with employment. And you will see lots of employers that do give benefits, employee benefits around childcare, marriage, holidays, health insurance. So they're almost addressing the other sides of someone's life, but there are not that many benefits for employers who are caregivers. So one of the key propositions is that the employers offer the platform as an employee benefit, or they offer it as part of their social responsibility to not-for-profit organizations for their members. And the benefit there as well is that one of the problems we're trying to solve is becoming a benefit both for the employer and the non-for-profit organizations, is that usually when you are on that role of caregiver, you have to navigate lots of different websites to find doctors, different websites for information, different websites for nurses, different websites for dietitians, and so on and so on. And then you go to the not-for-profit organizations, yet another set of websites and information. So what we're trying to be is the hub where all of the information is in one place. And that way we're helping not-for-profit organizations to attract sponsorships and offer it for free. And that's good for the company who sponsors, because the logo can appear on the app as well. The content from the non-profit organization is on the app as well. So that's the main model we have. It's with employee benefit or a social responsibility sponsorship in partnership, usually with not-for-profit.
Sorry, I'm not sure if I understand well about the employee benefits. It means that the enterprise that are working in care, that is delivering services with caring, they pay for it and give to the employees as a benefit.
Not it doesn't need to be in the caregiving industry. Imagine any business will employ people who are caregivers. So for these caregivers,
so I have my mother with some Alzheimer's
exactly.
or whatever, so I give you, so could be every company.
Every company, yes.
Okay, I understand. Okay. Because we are, all of us in families are carers, so
exactly. And I think that's one of the main things here, is because there is no universal understanding of what caregivers are. Most of us think caregiver is someone who takes care of a family member, especially elderly family member. But that's not the case. There might be things that are accidents, child or a family member with a disability, chronic conditions. And because as with Parkinson's, the disease changes over time, someone might be a caregiver for a couple of hours a week, 40, 50 hours a week. So they need support, they need emotional support, social care, connections, finding information, finding people to connect to.
Okay, I understand. So regarding the artificial intelligence, it's very, so it's now on top.
Yes.
And it's very
it's
good.
trending.
So it's very good that you are included in your application and your platform. You tell something that you told something very important, that we cannot how can I tell, we cannot exclude the human relationship, but we can help a lot. Also regarding in artificial intelligence, what do you think, with your experience, are the burdens between the how help and how help? I mean, not substitutive and a person and human being, but how can we go further? Where are the limits? What can we do? What can we do? Can we do more? Maybe.
I think the approach we follow in here, it's almost more like educational.
Education.
You see, the whole app is based on recording information and searching for information, learning about things. But at the end of the day, you know, both the patients and the caregivers will have the need for that human touch and the need to talk to someone. And especially, you know, speaking from my own experience, but from our experience of the caregivers we work with, is that moment where you don't actually know what Parkinson's actually means. And you don't know how long is it going to be. And you need to speak to someone who has a bit of an experience. You need to understand the symptoms. This is where artificial intelligence can help you with almost like asking these questions, getting a bit of education around it. And the approach we follow is not an artificial intelligence chatbot, which is generic. It's not Google searching for things and hoping it will be the best content. It's being trained on content that is being, you know, clinically validated. It's coming from best practices from European projects, from non-for-profit organizations, for clinicians. So the content that feeds the answers is validated and it's not generic things. And I think that's the big difference here is specifically trained on specific documents and information.
You think that we can go far? Maybe we can go farther, and maybe the artificial intelligence can make some not only educational. Maybe if all the data, if they are aware that something is happening, something that is a trigger, I don't know what now, maybe the suggestions from the intelligence, the chatbot. I don't know if we are in this step, or maybe it is very dangerous currently.
Yeah, I think we are not in that game for a number of reasons. I think one of the things we see in the market, if you go into, say, the App Store or Google Store, you will find 350,000 types of applications. The types of applications we're building, there are very few of them. The majority of applications, what they're trying to do is to measure data and then give you feedback on what to do with that data. If you're, you know, you started getting, you know, slow gait, maybe you need to do this. If you're losing weight, maybe you need to do this. And it's definitely things that you could help patients with. That's not where we want to go, mainly because the experience of all of these applications, there's research where what happens is most of us, we already know what's good for us. We know good diet, exercise, you know, reduce stress. We all know these things. People are telling us these things for years. Yet we're not doing this. And it's what we're trying to do is our habits don't change that easy. And eventually we stop doing what our doctor says, what our dietitian says, what the common sense say, and we keep doing these things. And what is happening is you have applications that they're trying to use AI or anything else to change your habits. But the same way you stop going to the doctor because you know what they tell you, you stop using the app. So there might be some people who are fanatics about the apps, but these people are fanatics either with the app or a piece of paper. What we're trying to do is to help the people who don't have the money to buy the wearables, and they are not there to think about, you know, the habits, their everyday needs. When I need to do something for the person I care, I need to give them a lift, I need to cook food for them, get them dressed. This is what I need to do, and this is where I need help from my environment. And we're trying to target that space rather than the space with AI changing your habits. There might be good players out there. It's not the business model we're trying to address.
Okay, thank you very much. It's very interesting. In fact, I remember this last Congress of Movement Disorder Congress here in Madrid. I was in a conference regarding physical exercise, and it's perfect. It's very, very important in neurodegenerative diseases. And the neurologist says, okay, the problem is that we cannot go the people change their habit and start doing exercise. So we need this pill. Maybe they change the habit, start the motivation to do it. So
yeah, but who is going to be motivating the patients to take the pill?
That's it. So finally, they said maybe we need some coaching services. Coach in order to achieve some objectives. So,
yes,
but
the human interaction is very important.
Yeah. It is. So, thank you very much for you all for being here, for your generosity. And we are now in touch. I was working before with George and Aquilina. We can still be working with Parkinson Disease Association and only on the consortium. So I will write my so Spiros has our email, but I'm going to in a chat to write down our email. Okay, for you.
Perfect.
My colleague Maika Marin, that she's in charge of this project, E-Care4PD, Proyectos Parkinson Madrid, ORG. Okay.
Perfect.
So let's still get in touch. And thank you very much from her. You are very generous and for your time and your experience. So.
And thank you so much for hosting it and coordinating all the meetings. Thank you so much, Laura.
Thank you very much. So bye-bye. You have something? Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Nice to meet you all.
Bye.